And I think we are just about ready to get started. We have 22 people on board. Are you guys ready?
Hello.
Hello.
Hi, Kurt.
Everybody here?
Hi.
Hi. Okay, everybody. Welcome
Okay.
to the 12th PEP Zoom luncheon meeting. Do you believe we've had 12 of these things? I cannot believe it. And I'm so sick of Zoom. I cannot wait. And I know you guys feel the same way, to have a real meeting, to see people face to face and not do this Zoom business.
Go ahead and mute everybody. We're getting feedback from somebody's microphone.
Okay.
Which program is this?
I
No,
could
it's
mute
gone.
everybody right now.
What is PEP?
If you mute-
Tell Linda has it.
Okay, I just muted Edna.
There we go.
Okay, it's quiet, I think.
That's better. Wow.
Our speaker today is none other than Dr. William Stringer, who is the Pulmonary Rehab's medical director, our medical director for PEP. But his main job is professor of medicine at Geffen School of Medicine at UCLA. And he is a scientist at Lundquist Institute. He is a physician practicing at Harbor UCLA. He has spoken to us multiple times over the years on a variety of great subjects, from medieval medicine to Beethoven music to other issues in medicine. And it's so great to have him with us today. But as I do every month, and it's really important, is for all of us to thank the board of directors, because this organization would not exist if it wasn't for the hard work of the board that are producing the Pep Talk newsletter, writing the Pep Talk newsletter, printing it, collating it, running the website, running these Zoom calls, trying to find new lunch places. Your whole board has been working their tail off for the whole organization. So can you all give them a round of applause, please? Thank you, everybody. I also want to remind everybody that the board works for you guys. And so if you have issues, if you have concerns, don't hesitate to call any one of the board members or myself anytime and voice your complaint or concerns or whatever. I was just about to go into kind of an update on Little Company of Mary's situation, and Joseph is here with some new information from Carol. So I'm now going to introduce Joseph, and take it away, Joseph.
Okay, good morning, guys. As you know, since COVID started, we've had changes at the rehab that we're all aware of. Since the 15th of this month, as you know, in California, a lot of things have opened up. The masking requirements have been dropped in many cases. However, in the hospital and in clinics, things haven't changed. So at the rehab, we're still masking, we're still distancing. So there's no changes there. They're presently reviewing, I think many of you know that the pre-procedure testing for the hospital, if you're having any procedure done at the hospital, it's required that you have a COVID test prior to that procedure. Well, the hospital elected us to take that over. So our classroom has been used for that testing. And that they're now reviewing that, but it hasn't changed. We're going to continue doing the testing as long as it's required. So we've lost our classroom. Maintenance will remain closed for now because we're still under the same standards. So cardiac has become very, very busy with their patients. They don't have maintenance either. They come in for their visits. It's distance, mask, and then they leave. And that's the way it will be with pulmonary also. The downside for us on that is that we've lost our space. We lost our classroom. Then they gave us a conference room, which worked out really beautiful. We started videotaping the core and the yoga with Jackie and I, and it was wonderful. We had a classroom we could have people in. We still could only have 3 people max, but we had a nice classroom. Well, Women's Wellness Center took the conference room because they needed for a waiting room for their patients. So now we've lost the conference room. So now we don't have a place to even do the yoga and the core, and we can't do it in the hallway because they've been doing reconstruction and the hallway's busy. So we have to continue with the recorded sessions for both the core and the yoga. Let's see what else. And for teaching now with the pulmonary, I'm doing, it's just me for now, and there's good news coming. It's just me for now. And I'm teaching in the corner of the gym. They put up privacy screens. We put up privacy screens so I can do 2 people. I can't do any more. There's no room. So starting in July, the July class is starting on July 20th. I'm doing 2 patients at 10 o'clock, and I'll be doing 2 patients at 2 o'clock. So we'll have a total of 4 pulmonary patients, but that's all we can do. Good news is that we have a new hire for pulmonary. She will be starting in mid-August. She comes with good experience. She's an RT. She also has her bachelor's in exercise, and she says has some other things going for her that Carol and I feel that she's a very good choice for our rehab. So she'll be starting in August. And so it's right now status quo. And like I said, they're looking at the COVID testing and stuff. So stay tuned. We'll see what happens. Carol's also going to a meeting this next week because the mall has asked us to come back and start doing the exercising. So she's going to a meeting next week to see what that's all about. So stay tuned.
Well, thank you, Joseph. And
Thank you, Kurt.
as I said last month, things are not looking great at Little Company of Mary for our maintenance program, at least in the foreseeable future. And Carol made that pretty clear. And so I also said to you guys that the board was exploring alternate facilities and places for us to have lunch. A week or so ago, Jackie and I met with the director of a nearby exercise facility that has lots of promise. And the entire board is going to visit that facility and evaluate it, but I think it's got some excellent potential. And I'll go into details later, but I'd kind of like the board, the whole board, to take a look and bless off. It may just be that Jackie and I are excited about this place and the rest of the board may poo-poo the whole thing. So I want to get everyone excited and then find out it's not workable. But preliminarily, it looks very good. And we've also found potentially a restaurant. It's not a perfect Sizzler replacement. Nothing ever will be. But I think it hits on most of the buttons. But the board is also going to go to this restaurant and evaluate the private room there and the food situation and so forth. So hopefully very soon, we're going to have some good news. And speaking of good news, I have some really, really good news. Mark your calendars for August 19th. August 19th, because we're going to have a good old-fashioned PEP picnic at Victor Park. Huh?
Yeah.
So we're going to have a picnic face-to-face. You don't have to wear a mask if you don't want to. You do have to be vaccinated, however. But we're going to plan on having our first face-to-face event on August 19th, and it will be a picnic. And we're going to have Manny, the guy that we had the past several years, cooking the burgers and the hot dogs and all that. And don't worry about the rest of the side dishes. That's all being handled. So We won't have it a potluck, but we'll have a number of side dishes, and we'll fill you in on more information on that as it draws closer. But the great news is we're going to have a picnic August 19th. And Tom, you're going to help me put up the banner. Yes, you are.
I'm not going to be here.
Well, you can cancel.
You changed it.
You can,
In July, I would have been fine.
I know, but we can't do July.
I know that.
So you
But I'm
can
not gonna
cancel
be
your
here in
vacation.
August.
You can cancel your vacation. There's the, anyway.
No, I was laughing.
I want to remind everybody that our guest speaker today is going to speak until approximately 12:15. And then I'll unmute everybody and we'll have a Q&A, and Jocelyn or myself will recognize you. You can raise your hand like this, or you can, there's a little thing right here, reactions, and you can raise hand like that, and you get a little yellow hand in the corner. We've got a great speaker today, and I'm going to have Jackie introduce Dr. Stringer because she's worked so closely with him. But I got to tell you, Dr. Stringer is a stand-up guy, a great guy. I worked with him on many of the clinical trials I went through, and he's really a fine guy. And he rides bikes, so he can't be that bad. So Jackie, I'll turn it over to you.
Okay, thank
Hip
you.
running.
Our guest speaker today is Dr. William Stringer. He is a professor of medicine in the David Geffen School of Medicine at UCLA. He's division chief of pulmonary and critical care medicine and physiology and medicine. He's an investigator with the Lindquist Institute of Biomedical Innovations. And today he's going to talk about long haul COVID and the role of exercise rehabilitation therapy. So welcome, Dr. Stringer, and we're going to mute everybody.
Thank you.
So you're welcome.
I don't know if it's fake news or not, but I heard an unsubstantiated rumor that Kurt was going to actually buy the Sizzler chain and open up a site for. Maybe fake news, who knows? So what I'm going to talk about today is kind of long haul COVID, and I know that friends and family and may have been affected by this, so I know it's a little bit of a tender topic, but this is the phase we're going into now, which is dealing with the ramifications. And so I'm going to try to talk through that best I can, and there's a lot of things we don't know, and the best thing to do when you don't know things is do research. And I just wanted to articulate, as Kurt mentioned, we do clinical trials here. We do a lot of COPD research. We're always trying to find better ways to do things. As you know, medicine's not perfect, and there's lots of ways it could be improved. So research is the way to do that. Just on that specific topic, Dr. Abbasi, who's on the call right now, does have a trial that he's interested in, which is looking at the immunologic aspects of COPD. So if you're interested in participating in a clinical trial, either email us or call us, and we'll get you in and do an evaluation and see what you might be able to do. It helps each other, and it helps us get better as physicians. So what I'm going to talk about today is the ramifications of this. You've probably heard on the news, we just ticked over 600,000 people dead in the United States. Can you imagine if I would have told you a year ago that 600,000 people were going to die in the United States? I think you would have laughed me out of the room. But we've actually had more people die in 2021 than we did have in 2020. It's true in California, it's true in Los Angeles as well. And the January, December area of this year, this last year, and this current year were about as trying as we've ever had at Harbor. But we did endure. Things are getting better, but now we're having to deal with the long haul COVID stuff. But one thing I wanted you to notice: this is a counter that's done by Johns Hopkins, which is one of the first public health institutions in the United States. You can see that that's over 2 billion doses of vaccine that's been administered already. And unfortunately, some of those are double dose vaccines, so they're not quite that many people, but it is important. So the best way to avoid post-COVID symptoms is never gets COVID in the first place. But that's obviously in a lot of people is not going to be possible. They've already got it, and now we have to figure out how to do something about it. I'll be back to vaccines a little later. There's some interest in vaccines actually improving some of the long haul COVID symptoms. So I hauled this out of the Washington Post. What they're looking at here is what states have more or less vaccination and what states have more or less cases. So this far left quadrant here is not very much vaccines and lots of cases. And Wyoming takes the cake right now. So hopefully you're not planning a trip to Wyoming. Down here on the right is not very many vaccinations and not very many cases. And that's where California is down there. Now, the two anomalies are these two quadrants. So this quadrant has lots of vaccines, but has lots of cases, and that's Oregon, Washington, and Colorado. And then this group down here doesn't have very many vaccinations and doesn't have very many cases. And Ohio, Tennessee, some of the Midwestern states are in that group. So it's not a perfect way to get rid of COVID, but it's certainly the most important intervention that we have right now. So vaccination is super important. So we've been talking about for quite some time that COPD was going to take over as the third leading cause of death in the United States. That's now been pushed back by two things. One is heart disease and cancer is always the first and second. That's about 600,000 people. But COVID here was 345,000 dead in 2020. And the stroke is in here as well, 159,000. But COPD now has been kicked down to about fifth or sixth. Unintentional injuries includes opioid overdoses.
Yeah, I am. All right, okay.
So that's actually pushed us down a little bit too. Okay, so here's what I want you to think about. So this is sort of the start of your life down here, and this is all the way towards the end of your life. And the quality of life across time does change, unfortunately, and we try to keep it as high as possible. But imagine somebody that's in their 20s who has an acute decrement in their quality of life. And then there's sort of three trajectories that could occur after that. One is it goes back to essentially normal and lives out the rest of their life. One is have some disabilities, but still has a normal lifespan. And the third one is lots of disabilities and a shortened lifespan. So there's lots of outcomes that might occur from somebody that's 20 years old having COVID that now manifests potentially throughout their whole life. So the quality of life could be really adversely affected. So this is actually a picture from the Central Valley in the 1930s. A lot of people came from the Dust Bowl, Oklahoma, Texas, those areas to California because there was jobs and obviously the climate was much better out here. So just backbreaking work, even back then. This is a picture from 2006. Again, backbreaking work. You can imagine how tough that is, but also working in very close proximity to other people because of these harvesters that are boxing up produce. So it's the ideal milieu for transmitting COVID. This is workers in a citrus farm. So if you look at the Central Valley of California, you're 40% more likely to die if you lived in that area relative to any place else in California. So the toll on this particular group that basically had to go to work, wasn't able to stay at home or commute through Zoom or whatever. This was a devastating amount of death and dying. But it also means that that group is going to have a very high rate of long haul COVID. So this is kind of healthcare inequities in the United States. The wealthiest 1% of men in the United States are living 15 years longer on average than the poorest 1%. And that's manifest, if you look at people that make less than $50 an hour, that Hispanics and Blacks actually are the most highest percentage there. So those are also the people that have had the greatest amount of death and hospitalization and cases related to COVID. And this lowest quarter down here of income is also the people that have lost the most jobs. So it's had really a devastating effect on our socioeconomic status in that the poorer groups have actually become poorer, have had a greater amount of death and disability, and will likely that will continue because of long haul COVID. So there's going to be manifestations that are that sort of multiply across time. So what I'm going to talk about is that as a background is some of the chronic symptoms, some of the physiologic changes, some of the immunology that changes, and then can exercise actually help that? And then look at a couple of specific symptoms, which are brain fog and fatigue, and how we're dealing with that at Harbor, which is setting up a long haul COVID clinic. So the symptoms, this is kind of what happens from time zero when the virus infects you, a couple of weeks, and then you develop symptoms, you shed virus, and then by 2 to 4 weeks, the virus shedding is gone, and we consider those COVID recovered. But then all the long-term ramifications begin in a large percentage of people. We don't know what that percentage is right now. There's large epidemiologic studies that are looking at this. And I'm going to show you a couple of ways to get at this, but that rate could be somewhere between 5 and 40% of those people have persistent symptoms at 6 months. And we're going to go over these symptoms here in a minute. So this is an article that looked at a whole bunch of other articles and looked at how many of the symptoms and how long they lasted. So if they lasted somewhere between 2 and 6 months, they called that long haul COVID. Any symptom here was about 70% of people. So some symptom occurred post-COVID in 70% of them. Dyspnea and fatigue here at the top were the actual most common. General pain, discomfort, and impaired mobility. And fever actually also was prevalent in somewhere around 20%. So there is a tremendous amount of symptoms. There are devastating symptoms, including fatigue, shortness of breath, inability to move around, pain and discomfort in joints. So there's a lot of things that we're going to have to deal with. It doesn't seem to have anything to do with whether it was mild or severe, although there probably is a dose response. The people that are in the hospital or in the ICU have dealt with the deconditioning that occurs in the hospital, but even the people that had mild illnesses or no symptoms at all can develop post-COVID symptoms. It seems to be an immunologic reaction post exposure that actually causes this ongoing symptoms, almost like an autoimmune type mechanism. So these are 6-month values from Wuhan, 1,700 patients. The most common symptom at 6 months was fatigue or muscle weakness, but sleep disorders and anxiety, depression actually are very common. So these, which are very non-specific things like sleep disorder difficulties, can show up in this population and need to be addressed. And they're looking at this group that was hospitalized all the way up to intubated. They weren't looking at ambulatory people, and they weren't looking at people that were asymptomatic. So this is just to remind me to tell you that these are multiple studies, multiple places in the world. That China study is the biggest with 1,700, but Italy, France, Spain, every place that had huge outbreaks has looked at post-COVID symptoms. They followed them somewhere between 2 months and 6 months so far, and the year data will come out soon from Wuhan. And just a tremendous amount of problems, respiratory, joint, general fatigue, muscle pain, just all those kind of, how bad you feel when you have viral infection seems to persist, and that symptoms of being just fatigued and worn out, post-exertional malaise, that persists across time. And there's also a large amount of sequela, which you mentioned, anxiety and depression, but PTSD and things like loss of taste and smell. So you can imagine food no longer is very interesting because you can't smell it, can't taste it. So that contributes a lot to some of the difficulties with weight gain and proper nutrition. And then just any organ system in the body can be affected. So those are people that were hospitalized. What about people that compared to other people that were hospitalized at the same time? And if you weren't admitted, did you get symptoms? So this is a Danish study where they have electronic medical record that everybody in the in the group is actually tracked across time. So you can actually query the database to what's going on. So they took 10,000 people that had COVID and hospitalized or not hospitalized, and a similar group of 80,000 people that were also non-hospitalized but COVID negatives, matched with age, gender, and time window. And what they found was that the people that were COVID positive had a greater likelihood of being diagnosed with dyspnea or a blood clot, and they also had more outpatient visits. Now, this is a query of data that isn't specific to individual charts being reviewed. This is just a query of their database. But it shows you that even if you weren't hospitalized, you're going to have greater use of healthcare resources and have greater risk of things like shortness of breath and blood clots. This is a cohort study where they actually did a web survey. They sent this web survey to people. The web survey took 69 minutes to do 257 questions. So that's a pretty intense web survey. Usually if it's more than about 2 pages, I sort of give up when they're on these web surveys. But anyway, these people were very persistent. Only 8% of those people had been hospitalized, but most of those people, 96%, were having symptoms beyond 90 days and 65% at 6 months. So the good news is that the symptoms seem to relent across time. The symptoms are higher at 3 months than 6 months, and that we're hopeful that continues across time, but we don't have data past 6 months currently because of this epidemic is just slowly rolling out. This is interesting too. If you just sort of look at this left side graph, the mild symptoms or very mild symptoms is this green here. You can see that the symptoms are increasing across time, as opposed to very severe symptoms like this sort of orange and red that start very severe and then seem to tail off across time. And then the moderate symptoms actually seem to persist. So the mild symptoms and moderate symptoms are becoming more prevalent. The more severe symptoms seem to be relenting at 6 months. So that's somewhat reassuring, but it's also a little bit disquieting that some of the symptoms are actually being augmented or perhaps being perceived more as you go across time. So I want to sort of introduce this idea of post-exertional malaise. So the idea would be you go out, you take a hike, and then the next day you're just worn out, as opposed to normally you sleep at night, maybe a little sore in the morning, but your energy level's okay. So post-exertional malaise is very common with post-viral symptoms. It's seen in chronic fatigue syndrome, and it's very common in COVID as well. So what they did is they actually looked at a group of people. They found that their work schedules were actually still abnormal. 45% still had a reduced work schedule, and 22% were not working at all because of their health conditions. And it was very common to them to have multi-system issues and symptoms. So this is the group that had remaining symptoms at 6 months. And again, fatigue, malaise, brain fog is sort of difficulty concentrating, difficulty with memory, difficulty with sometimes speech. Those are very common in this group. But if you had post-exertional malaise, which is this top up here, those people at 6 months had much higher rates of exertion, post-exertional malaise, but fatigue, brain fog, those kind of things, as opposed to people down here that either didn't have post-exertional malaise or the malaise had now resolved so that they could do exercise and not feel bad the next day. So that seems to be a marker for this immunologic abnormality being active or starting to relent. And it may be important as we think about exercise therapy of these people with post-exertional malaise are going to need very gentle programs to bring them up to speed, as opposed to people without post-exertional malaise, where we may move towards our usual sort of interval training and progressive exercise therapy. So if you may not spend a lot of time on your phone with apps, but there's this thing called the COVID symptom study you can download. You can put in your symptoms every day. It's run by some people at Harvard and in King's College in London. So what they did was they asked people how they're feeling each day after their COVID was positive. So they sent them a little link that said, you want to sign up for this app and to give us your symptoms each day. So what they found was that most people's symptoms were gone in 11 days, but even 4 weeks, 8 weeks, and 12 weeks, they found still a reasonable number of people. So if it was 1 in 20, the United States or the world would have about 8.4 million cases if it was 1 in 20. So we don't know what this number is. This is just a way to estimate it, but a tremendous number of people are going to have long haul COVID. So what's wrong with their lungs, for instance? So what we find is they have a mild restrictive ventilatory defect, which means their lungs are stiffer than normal. And that stiffness manifests into reduced exercise capacity. They also have a reduced gas transfer, DLCO. That's the marker for oxygen being able to move across your alveolus. So they have physiologic changes. They also have anatomic images, anatomic abnormalities. I'm going to go into this too much here, that you'll see as well. So one of these studies actually just took people and did MRIs of sort of the entire body post-COVID. And what they found was, I'm going to show you on here. Some of these people had been admitted up to 8.5 days, but what they found was their exercise capacity was abnormal. And they tried to correlate that with things like white blood cell counts and other things that might actually manifest as markers that could be done in the blood. They also did a whole bunch of interleukins and cytokines and other immunologic markers. But even brain health in these people post-COVID, they actually had abnormalities in their brains that were different than control populations that had been hospitalized but didn't have COVID. So there seems to be multiple organ systems, heart, lung, muscle, brain, et cetera, that's affected by this. And you can see that with imaging on MRI or CT scan, and you can see it in some of the persistent abnormalities of the immunologic markers. I'm going to show you that in a minute. So this is the outside window would be doing well 100% in all the different areas. So like no pain, good general health, physical functioning, and then physical, emotional, energy, et cetera. You can see the COVID patients are in here compared to people that have been hospitalized. So they seem to have an additional deficit in lots of different domains of their life, you know, from physical to mental to sort of overall well-being and energy. So this is particularly important, it seems to be, in energy levels and emotional impact of the disease. So speaking of these immunologic changes, I'm going to just show you this. So some of you remember the original SARS that was in the infection that occurred in China and also in kind of a large outbreak in Canada. But that was controlled, but that also used the ACE receptor, ACE2 receptor, which is what SARS-CoV-2 binds to. MERS, which is Middle Eastern Respiratory Syndrome, binds to a different receptor on the surface. But all of them seem to have very similar ramifications in terms of immunologic function, but they have markedly different mortality rates. So MERS, the mortality rate for MERS was about 35%. SARS, depending on the current COVID, whether it was severe or not, could vary between less than 5% up to 45%. And then the COVID, the original COVID SARS was about 10%. So markedly, we would have had literally double the amount of mortality in the world if this would have been SARS-CoV rather than SARS-2. So it's important to remember that, you know, we may have actually gotten a much lower mortality out of this than we could have potentially had. Can you imagine what it would have been, 30 to 35%? But these are all coronaviruses, and there's lots more of them out there in the world and in labs. So this may not be the last time we see COVID. But what happens is a lot of the markers in the blood go down, but a lot of the immunologic markers, IL-1, 6, and 10, they're cytokines that increase the inflammation are all up. So you can see that this disease is increasing the neurologic or the total body impact of inflammation in the brain, in the lung, in the liver, digestive tract, skin. That inflammation seems to continue on in an almost an autoimmune type fashion that we see with things like lupus and rheumatoid arthritis, et cetera. So some of the things that actually may turn out to be markers of long haul COVID are these autoimmune antibodies. There's still a lot of research going on that. And also the long-term abnormalities that occur in T helper cells may actually be related to changing their genome or their epigenetics, so that you begin again to attack yourself. So when you're a tiny baby and you're born, you learn to delete those antigens that are in your own body, so you see self and non-self. It seems to upset that self versus non-self, so that now you begin to see things that are in your own body as non-self and attack them. So this is actually very similar to what we do in lung cancer, where we use the PD-L1s or the CTL4. We actually unmask the tumor so that the immune system can attack it. But what that means is you can get itis in essentially any place. So your brain, your liver, your lung, your bones, your skin, you can get inflammation. And so this seems to be kind of a more acute model of what is going on with COVID. But again, there's a lot of research that needs to go on until we better understand this. And obviously the way to tone that overactive immune system is what we want to do. So the question is, does exercise rehabilitation actually do that? As I mentioned before, chronic fatigue syndrome or myalgic encephalitis is frequently accompanied with fatigue, brain fog, and actually post-exertional malaise. So I don't know if you had anybody in your family that's had chronic fatigue syndrome, but fatigue that lasts more than 6 months, and this post-exertional malaise seems to be very prominent, where they're just out of energy the next day if they do something, and they have to be very careful about titrating their energy throughout the day. So, you know, is long haul COVID the same as chronic fatigue? No, but there may be analogies that we can move from there to here. This happens to be a study where they did exercise rehabilitation in patients that had chronic fatigue, and they did an exercise intervention with those people. That green there is graded exercise therapy. You can say they had the most improvement with that and cognitive behavioral therapy, and their physical function was most improved by exercise and again the cognitive behavioral therapy. So whatever we do with exercise, we're still going to have to think about other cognitive interventions that actually help these people. It's not going to be just exercise. This is just a recommendation with chronic fatigue that exercise is graded exercise, and then starting gently is actually indicated in this group. Okay, so there are now sort of recommended interventions for fatigue, for shortness of breath, and not neuropsychiatric implications. I'm not going to talk about those too much, other than the CDC has now issued some recommendations about how to evaluate them and potentially how to treat them. But what I'm going to really focus on is exercise rehabilitation. In this particular study, they took 99 patients that had had COVID, and they were post-COVID acutely, and they compared that to other people who came to pulmonary rehabilitation for other lung diseases, and that could be emphysema, interstitial lung disease, whatever. And so there's almost five times as many people that were doing the regular pulmonary rehab versus COVID. It was 3 weeks, was pretty short, 25 to 30 sessions, so that was pretty intense, and 5 to 6 times per day. They did exercise, strength, as well as aerobic, gymnastics, outside walking, etc. And they adapted it to the physical capacity. Specifically, if the 6-minute walk was less than 200, they started with the lowest intensity, and then they tried to bring them up with a goal of a Borg score, which is kind of a medium Borg score between 4 and 6. And then they monitored them for desaturation, and it was done by a physical therapist. I'm going to skip this part. What they found was that when they got done, they really weren't any different than the people that had been in pulmonary rehab for everything else. So this is a sort of a feasibility study. Can you do rehabilitation in post hospitalization on COVID patients? The answer is yes, and they seem to have the same kind of outcomes as people who would normally be going to pulmonary rehabilitation as part of say a recent exacerbation, recent hospitalization, and being put into rehabilitation. Something that's interesting is that the COVID vaccine, I told you I was going to get back to that, it may actually be a therapy. So if you look at the amount of symptoms, and the blue is essentially improved, the green is unchanged, and the yellow is worsened. So these are unvaccinated people. These are people who have been vaccinated. And what you can see is the blue increases in all these different areas. The green is pretty much the same, although it's maybe a little bit less. But this worsened part of it is much lower. There are a couple of places, fatigue and brain fog in some groups has actually gotten worse with vaccination, but the vast majority of people seem to be actually improving with the vaccine and all their different symptomatologies, specifically the fatigue and the breathlessness. So that's encouraging. This is a very early reprint. We'll see how other studies, this isn't the biggest study, but this is 8-month follow-up. Those people came from some of the original vaccine trials. Okay, so let's talk just a little bit about brain fog. This is sort of like when you wake up in the morning and you're not quite all there, or can't really concentrate or can't really remember things. And even early Alzheimer's has been contrasted with this. And it certainly could be exacerbated by anxiety or depression, but it's its own area. This is kind of the usual recommendations, and this is kind of like mom and apple pie, right? Do regular exercise, eat healthy, get sleep, reduce stress, don't have too much caffeine. So, I think, your mom could have told you that. So is there anything more specific that you can use for brain fog? Well, since this is a COPD group, I thought you'd find this interesting. They've used nicotine in a patch, not in a cigarette, to actually treat people with mild Alzheimer's and amnestic. And what they found was that they actually seem to have better cognitive scores. And this was they tested attention and psychomotor things as well. So that's kind of an interesting idea. This is just saying the same thing, that brain fog that occurs in early Alzheimer might be affected by nicotine. This is another group where they actually looked at people that had chemotherapy. And if you've had chemotherapy, I can tell you your brain doesn't work as well afterwards, and it takes some time for that to come back. They tried to give these people nicotine to see if it would actually help them as a patch. This study was too small to really come from an outcome, but I have the feeling that we're going to see a long haul COVID nicotine trial here, and it'll be interesting to see if it actually comes out positive or not. So this is the other part that I think is important, is what you folks are doing, which is, interacting with each other, having a community that supports each other, talking about things, helping each other, having outings, realizing that life goes on. Those are all super important things, and they're slowly being developed for people that have had long haul COVID. There's groups on Facebook. I'm going to show you a couple of support groups. They're all there. And then the NIH has devoted a reasonable amount of money to study post-acute sequela or long haul COVID. This is one of the biggest long COVID alliance. And a lot of these groups put together other groups like the chronic fatigue people that also have very similar symptoms, hoping that this new research will help them deal with their symptoms. So this is also just not our country. I like this one. This one came from India, but here's the little COVID virus with the spike proteins. You can see the little chains going to the person in all different parts of the body and holding them back. So I thought that was a nice visual of what's going on. So what are we doing about it? We're setting up a post-COVID clinic here at Harbor. The important thing is to try to improve the organization so that the care can be not only individualized, but optimized for that patient so that they don't have to run around to 10 different clinics. And these are people that don't have a lot of energy, don't feel good. Going to a bunch of clinics is not going to be a good idea. So we're trying to set up a lot of this virtually with either video or tele or both. And then we want to keep track of their symptoms, make them the newest research in terms of what can be done for those symptoms, and then enroll them in clinical trials, because a lot of these things are not going to be settled until we get them into clinical trials. And then to provide education and training for the doctors here that are in training, so that when they go out, they'll know how to deal with long haul COVID and take care of those patients, and recognize some of these patients have classic long haul COVID symptoms, and they go by a bunch of doctors and none of them seems to look at them and go, oh, this is long haul COVID. So we need to teach our young doctors how to recognize this and to provide therapy. So we're thinking of a multidisciplinary group. We've set it up with both virtual and on site. And then we have an electronic referral system that we do. And then we work closely with the PCPs. And we are attempting to set up a exercise rehabilitation clinic here and a exercise rehabilitation program with Jackie, who is nicely offered to help us get going. So these are the types of symptoms you can see in all different types of the body. These are all different specialists that you might see in the hospital, right? Cardiology, neurology, pulmonary. We're trying to put those together so when the patient comes in with, symptoms from different areas, we can get them therapy, diagnosis, and access to all those subspecialists through a virtual conduit. So this is how we're setting it up. That's me, Dr. Stringer. Dr. Witt is an ID specialist, and Dr. Wright is a neuropsychiatrist. They're all experts in what they do, and the three of us are putting this clinic together in rapid fashion. But research in COPD is important, research in long haul COVID. There may be things that come out of long haul COVID that help other diseases. We talked about chronic fatigue, but I have the feeling that we're going to find things about lung disease that will help us do a better job for you. If you go on to clinicaltrials.org, you can see all the clinical trials that are being evaluated. A lot of these haven't finished yet. They're still enrolling. And then this is, somebody's got their, yeah, I'm gonna have to mute something because I can hear like an echo. Sorry about that.
Somebody,
Yeah, just mute.
I'm muting everybody.
I think that's better.
Dr. Stringer, will you unmute again, please?
I muted everybody, including Stringer. Dr. Stringer, can you unmute
Yeah,
yourself?
there we go.
There we
You
go.
were probably tired of hearing me anyway.
No,
What
we
I was
weren't.
saying is,
Not at all.
so we can do studies on our patients in the hospital. We can do studies in our research lab. We have similar equipment. Same thing with exercise testing. You might recognize that guy on the bike. That's one of our fellows. We do bike and treadmill. And then we've actually set it up to deal with COVID. It's a high flow room and a plastic barrier so that if there's anything aerosolized, we can do it. And most of our patients are immunized now, so that's really not a big deal. And then this is the exercise rehabilitation area. This will be Jackie's domain here very soon. We'll put to where we can do aerobic, we can do strength. We can check people on a biodex, which checks strength in different muscle groups. And this will allow us to participate not only in the clinical care and improve the care of the patients, but also document for research as we go forward with various studies. So the CDC actually just put out their guidelines, which really weren't very helpful. It's kind of a mismatch of what I've just told you. But there are some interesting things in there. Women appear to be more common than men in terms of developing both chronic fatigue syndrome and long haul COVID. And then the other part is we don't have a great definition of long haul COVID because there's so many different symptoms. We're not sure how many people go on to it. And we're starting to look at ways to have a blood test to diagnose long haul COVID, but I don't think that we're going to come up with something that's bulletproof or ironclad. And I think the most important thing is when a patient has these symptoms, to believe it, to get on with it. A lot of the people couldn't get tested or didn't get tested at the start of the pandemic when they probably did have COVID. And now I think the most important thing for the healthcare community is to believe their symptoms, move forward and find, therapies for them. Okay, so yeah, you probably don't need to know any of that. Patient support groups we already talked about. This is the way that we're trying to set up standard ways to code this, not only us, but the United States, so that we can keep track of how much is being done. And I talked about the NIH initiative already. So anyway, that's the end of my talk, but it's really just the beginning because we're just starting to understand long haul COVID. And my hope is that not only we get the research done, but that we get the care for these people so that they can feel better. And it isn't just sort of tincture of time, but it's, interventional therapy for their symptoms, whether it's fatigue or brain fog or neuromuscular, neuropsychiatric, et cetera. So anyway, I'll quit with that and I'm happy to take any questions you folks have.
Dr. Stringer, first of all, thank you on behalf of everyone at PEP. We are so We are so lucky to have you as our medical director, you know, a guy that's on the leading edge of research on COVID, on pulmonary diseases, on so much. We're so lucky to have your time, and we want to thank you for taking the time to talk to us. And with that, we'll open it up. We have 15 minutes of questions, and Dennis, let's have Dennis first. And he's I think a kind of a long hauler, short hauler, good hauler.
Anyone else who has a question, raise your hand. I'm going to make a list in the chat box so we can keep track of you.
Thanks, Justin.
Hi, Dr. Stringer.
Yes, sir. How are you?
I'm okay, thanks. I saw Dr. Hom yesterday.
Yeah.
I believe you should check in with him soon.
Okay.
'Cause he has some news for you. And I want to ask you, first of all, thank you for that presentation. And I learned quite a bit there. And then my question to you is, what do you think could happen to someone like me or has long haul if they got the flu or a cold? Could we more easily fight it off because of vaccinations, or could it be devastating, or is it unknown?
Well, the answer is it's unknown. My hope is actually that because this immunologic activation is going on, that it actually may be better with another encounter with a virus or some infectious agent. But there is certainly the possibility that either something has been weakened or something else where it actually would have greater ramifications. I prefer to believe the former, but it's a hypothesis, right, that needs to be tested. And so it's a great question. I have no great answer, unfortunately.
Joseph had a question. Joseph, go ahead and unmute yourself. Joseph, unmute yourself first, please.
There, am I back? I'm back. Okay. Two things. The Delta variant, is this a concern for us?
I'm sorry, the Delta variant, the last part kind of got cut off. What was that?
The Delta variant, is this a concern for us?
Well, the answer is that most of the studies looking at vaccinations have shown that the Delta virus isn't a problem. It is a big problem if you're not vaccinated, or if you couldn't get vaccinated because of medical reasons. So it just reaffirms the, you know, social distancing and masks and wash your hands and all that. But if you're vaccinated, it seems to have the same efficacy with the Delta, and we're now using alpha, beta, gamma, delta, because we're trying to get away from locations in the world. So the D is the India virus. A is the original one that was found in the UK. B is South Africa. C is Brazil. So those don't seem to have effect on people that have been vaccinated, but they seem to be more infectious. And there's some data that the Delta may have greater morbidity and mortality. It's certainly something to worry about. And then it's not going to be the end of these variants. The longer the entire COVID pandemic goes on, the more time it has to mutate. So it's self-interest for us to get vaccine to every place else in the world, because it doesn't matter where it's brewing. It could be causing a variant that actually breaks out of being controlled by the vaccine. And there's a whole bunch of smart people that are trying to figure out whether we need to be revaccinated or not, and whether we need to add different variants. That answer isn't in yet. But what we do know is that the original people that were vaccinated in the original clinical trial for Pfizer, so those were being done, you know, a year ago now. They have a year follow-up. They still have good antibody levels. So the answer is that we probably may be able to get away from not revaccinating this fall, but that depends on what's going on with the rest of the world. And if some, you know, mega variant comes out, we'll have to vaccinate people against that variant. The last thing I was going to tell you is the DARPA, which is the Defense Advanced Research Council. It's run by our government. All sorts of good things and bad things have come out of DARPA. But what they're trying to do is immunize the troops against every spike protein that Corona has. So the vaccine has about 25 different proteins, so that no matter what coronavirus they saw, our fighting force wouldn't get infected. that's probably what's going to happen to them. So you just got the COVID-19 variant. They're going to be vaccinated with essentially the whole cycle of that. And so we may see some complications of in that group as well. They're young people, but they're going to be vaccinated against a whole slew of them.
No. Second part, just about masking. You know, there's so much going on with opening California and being able not to. If you're vaccinated, you can. What's your opinion with the masking with our pulmonary patients?
Yeah, the problem with vaccines is that it's a certain percentage out of 100, right? It's not 100%. So I think that the best thing to do when you're going out of your house is to have a mask on. Obviously, I'm biased. I still wear masks outside. I mean, I don't have lung disease, but I want to stay healthy and I don't want to get sick. And so, like I said, the best way to get away from long haul COVID is not to get it in the first place. But after you get it, I think that making sure that you're using the mask and everything else with lung disease makes total sense. And then as we go down the group, once we have a rate that's in the background that's very low, I think that there may be some considerations. But at this point, the mask should stay on as long as you can possibly keep it on. I know it's uncomfortable and it doesn't make things better in terms of human interaction. But the good news is if your family have been immunized, then you can be around them without a mask on. And I think we can sort of get back to some normal social interactions that are so important to keeping us happy.
Thank you.
Dr. Stringer, I have a question. You were talking about the vaccine as a therapy. Is that referring to someone who just gets COVID and lessening their symptoms and their duration, or is that a therapy for long haulers?
Okay, so that's a good question. So we don't recommend vaccinating people until 60 days after their initial infection because they seem to have more reaction to the virus. Somewhere between 60 and 90 days, they should get the vaccine because the immunity they get from the vaccine is more wide-ranging than the initial infection, and it specifically induces IgG, which is in your blood, which is the one that keeps you from getting deathly ill from COVID. Now, the therapy for it is that when you've had COVID and you have long haul symptoms, they've now looked at those people, the ones that have been vaccinated against the people that weren't vaccinated. And there's lots of reasons why you might be in one of those two groups, but the group that did get vaccinated had less long haul symptoms, had reduction in the vast majority. There were some that actually got worse with the vaccine, but the vast majority of them either got better or stayed the same. So I think it's important to get the vaccine, not before 60 days for sure. And then the jury is still out on bigger studies. That's not a giant study, a bigger study that really shows that vaccines do, definitively improve it or not. It takes a few studies and that the concordance of multiple studies to actually really understand that it is a real effect.
And I have another question. I still have quite a few people in my life who do not want to get the vaccine for various reasons. Are there any resources that you like for informing people about the science behind it and its safety and maybe giving them a good resource for their information?
Well, the thing I think works best is talking to people. I'm happy to talk to anybody that's in your life that's not vaccinated because I think it's so important to get vaccinated. I have people in the hospital. I had to almost physically take them over to the vaccine clinic because they wouldn't do it. These were high-risk people with diseases. But there's a lot of suspicion about healthcare. There's a lot of false information about vaccine. Vaccines aren't perfect. There are people that have reactions to them, and the reactions sometimes can be severe. But the answer is that those are so small compared to all the morbidity and mortality we get out of COVID that you have to, stack the risks against each other. I think that the problem is that when there's a bad outcome, it gets publicized. You don't see all the millions and now billions of people who have actually gotten the vaccine who've done fine. So I'd be happy to talk to them. The CDC has all of this data on their website, but it's not very digestible. I think it's more important to come from somebody who you trust, and hopefully that's your physician trying to convince you to do it. But I think there will be people that don't necessarily want to do it. And once we get to a herd immunity, those people are going to benefit from all the people who did get vaccinated. But I would rather see them in the vaccinated group. And, you know, as new variants come through, you know, we may find that masking and other things is not as effective as it was before because they actually have additional virulence for infection. It's frustrating to me, but you know, there's a lot of people that don't like vaccines for a variety of reasons, and it's been all mixed in with politics these days, and that's a mess too. But I think that the science behind it is rigorous, the data collection is rigorous, and you have to believe in science because science may have got us into this, depending on where the actual virus came from, but science is going to get us out of this. And you know, just being somebody that says I'm not going to do something, that's really not too helpful when you need the whole community to really work together. So the more people, the better. It'll never be 100%, but the higher it can be. And just encouraging them to get back to their normal life, I think, is the most important thing. You know, if you can't go hug somebody because they're not vaccinated, or you have to wear a mask around them, or, you know, can't see your grandkids, whatever, that I think has been the most powerful thing, separate from the science type of argument.
Dr. Stringer, what percentage of vaccinations have to occur before we have herd immunity?
Well, I wish I had an answer to that too. It's been all over the map. Traditionally, it's been above 70% in most infectious illnesses. Now, I've heard estimates that have to be higher, and I've heard lower in COVID. So you can take your pick. You're a smart guy, Kurt. There really isn't a great answer to that. So what Tom's saying, he doesn't think that you're a smart guy.
Because he's a smart ass.
Well, that's another use of the word smart. So, but anyway, there's no great answer. Actually, honestly, there's going to be a lot of analysis of what we did, what we screwed up, what we could have done better. And one of the things that's going to come out of this is what does it take for herd immunity? I'll give you a quick example. In California, in January, we were just about to break. In Los Angeles, we were just overwhelmed. And then it went away. It just went rocketing down. This is actually what's happening in India right now. And it can't be because of the vaccine, because there wasn't enough vaccine circulating in January and February in Los Angeles to make any difference. And there's not enough vaccine in India to make a difference. So epidemiologists are working fervently and trying to figure out why we dropped in California, because I don't think anybody was wearing any more masks, and the vaccine couldn't have done it. So either it ran out of potential customers, which is kind of the herd immunity thing, or the virulence changed and mutated to something else, or something else that we just don't know. So it's a huge question mark. I mean, maybe we never find an answer, but the good news is it went away. The bad news is that it's not something we're going to be able to reproduce until we understand it.
Okay. I think we're out of time, and you probably have to go back and do some research. So once again, Dr. Stringer,
I got my clinical scrubs on today, so I'm taking care of the ICU.
Thank you so much.
Take care, everybody. Stay safe. We love you.
Thank you.
Bye-bye now.
Someone started a screen share.
I am going to stop the video.
There we go.
Stop the recording, rather.